We're good to start, sir.
Thanks. Welcome to the Tuesday webinar which we regularly conduct in 7 to 8 p.m. So, continuing with our series of extracorporeal life supports, today we are actually bringing in front of you a unique form of extracorporeal support which is used in lung transplantation. So, this particular process is called the ex vivo lung perfusion, which helps us in optimizing the donor lungs after we have explanted them from the donor before we implant them into a recipient. So, this is a wonderful technology where uh, the donor lungs are actually placed in a separate entity, and they are optimized by medically treating them of their pathologies while they are actually outside the patient's body. Hence the term ex vivo lung perfusions. So to bring about more details regarding this ex vivo lung perfusion, we have today Dr. Vimi Varghese, who is a transplant pulmonologist with us at Yashoda Hospitals, who is trained in Belgium in lung transplantation. And along with us as an expert panelist, we have Dr. Ram, who is who is
Sir, I think your sound just got cut off in between. Yeah, now.
yes, I'm audible.
Yes, yes.
So we have a Dr. Ram who is a lead for pulmonary thromboembolism and chronic thromboembolic pulmonary hypertension, and along with lung transplantation, who is an intensivist in Arizona. So we welcome you here to be our expert panelist. Over to you, Dr. Vimi sir,
Yes.
to continue with your presentation.
Okay, is the screen visible, sir? Is the screen visible, sir? About the slide visible?
Screen is visible, sir.
Okay. Thank you, sir, for the
Yes, sir.
introduction.
Slides are visible.
Yes, sir. Thank you, sir, for the introduction. So, how we are planning to do this presentation is I'll be giving a brief overview about the EVLP in lung transplant, about the different mechanism and how it has changed the donor lung pool as compared to previously. And our subject expert, Dr. Ram, will be speaking in detail about few things in EVLP and going to more details about how EVLP is conducted and how the results have been in the last 10 years. So as you know, we have a lot of recipients, and the donor lungs seems to be not at the same rate as we have the recipients. So as you know, when we go and evaluate a donor, 40 to 50% of the time, the donor will have some kind of an issues ranging from infections, the low lung compliance, or having a contusions, or there are a lot of factors that influence us, where the donor lung may not be good and we might be declining this donor. And on the other side, we have a lot of patients waiting for organ transplant, and we have to make sure that our waiting list mortality is less, so that it is essential from a disease perspective also. So right now the scenario is we have a lot of patients with heart failure or an end-stage lung disease that is requiring an organ transplant, and we have a donor. However, almost 30 to 40% donor we are not utilizing because of many reasons, right from the low PF ratios, infections, contusions, etc. And we might be declining this donor. So there is really a shortage of organ that is being utilized for an organ transplant, especially from heart and lung transplant point of view. Now we have different mechanisms for organ preservation. So we have for lung something called Vivo Lung Perfusion or EVLP, and we have something called an organ care system or OCS for heart transplant or for heart. Now, when we go for an organ retrieval, uh, there are many things that will not be very favorable for a donor lungs. So these are the I have written few factors, like 4 important factors where we strongly think how EVLP can make a difference. So that is when the best PF ratio, that means we usually take a PF ratio from the pulmonary vein and we sample, and if that PF ratio is, let's say, less than 300, so that is one of the donor where we feel that okay, it is not the right donor and we might be declining. And or when we do an inflation test and the lung is having a poor lung compliance in the examination during the procurement, or patient had received a lot of large scale transfusion, and there are other reasons like focal consolidation due to infections, etc., where this is not a right candidate for an for a donor lung procurement. So EVLP is a mechanism where we make sure that the perfusion is normothermic. We have a protective lung ventilation, and we are able to give a perfusate with an increased colloid osmotic pressure. Now, you might ask me, because of the 3 main principles about perfusion, ventilation management, and the osmotic pressure, how it is going to make a change. Now, because of this mechanism, this EVLP, so EVLP is like a mechanism where it is being connected, or it has 2 circuits where one circuit is attached to the pulmonary artery and other circuit is attached to the left atrial cuff, and this is being connected to an oxygenator and a filter, and we can do different samplings right from doing a bronchoscopy, as we can see on the left side. You can give an antimicrobial therapy, or you can have a different recruitment manuals from a ventilation point of view. So by all these 3 mechanisms, the lungs which is considered very unsuitable is being made to suitable, or we can recondition the donor lung and we can reevaluate the donor which is considered unsuitable, and we can have a different mechanism or different strategies to condition the lung, and we can see this donor lung improves after this management, and we can see how the data also which shows how it will change in the donor lung procurement. Now, this is one of the recent paper where you can see that this is a data of the from the Toronto team of from September 2008 to March 2024, where there is a call for 1,000 clinical EVLP cases, out of which they have been able to do transplant for 59 EVLP transplant recipients. So almost 65% of the 1,000 cases they were able to utilize that lung, and 29% of the whole transplant was being occupied by from an EVLP mechanism. So you can say that the donor pool has really expanded by using this Vivo lung perfusion technology. Especially we can reduce the waiting list mortality. We are able to give a solid organ transplant to a large number of population, and this has really improved the donor lung pool in the recent years. Now, I'm just going to mention in brief about what is an EVLP circuit. So you can see that there is a dome, as you can see in the center of the screen. You can see the donor lungs, and you can see 2 circuits. That is, there is a circuit from the left atrium through a special left atrial cuff, cuff, it is being the fluid is coming to a reservoir. Then there is a pump and there is a different gas exchange mechanism and a filter which is going to the pulmonary artery, and you have a endotracheal tube where it is connected to the ventilator. Now, this is a basic mechanism about what constitute an EVLP circuit. There are many different fluids, right from Stern's solution to a different fluid that is being developed from a Toronto team and from a Hanover team that is being used for while the EVLP is being started. Now, as I said, there are two main connections right from the pulmonary artery and another connection from the LA cuff. And this is the special LA cuff where the circuit is being connected. And this is the one that is connected to the pulmonary artery. And this is from the trachea where the endotracheal tube is placed, and this is connected to a ventilator. So now you'll ask me what difference it makes after connecting. So once the circuit is being connected, once the solution is started to flow, I will each hour you can do an X-ray. You can measure different parameters like from PF ratio, different pulmonary vascular resistance, and the compliance of the lung. So each hour I am measuring these factors, and there is a criteria for accepting a donor lung after the solution is being run by different teams, right from the Stearns or right from Toronto team to the Hanover team. And I think the next speaker will tell in detail about what is the criteria for acceptance. And based on this criteria, when the PF ratio or the pulmonary vascular resistance decrease or the compliance improves, that is an indirect way to understand that these are the donor lung which has reconditioned and which have improved after applying these measures, and we can take for a transplant. So I just want to show the different EVLP X-ray which is being taken at baseline or every 3 hours to understand how the clots or how the other consolidation or contusion, what is the change as compared to every hour or at a different timeline. So what is finally the difference that is made? So we are having a small donor pool previously that is made to a bigger donor pool with the help of an EVLP. We are able to condition the donor lung, which was previously told as unsuitable, by reconditioning by different forms through the antibiotics, through a bronchoscopy, by reconditioning the lung by applying different solutions so that the compliance can be improved. And we have a different set of criteria, as I have mentioned, so that the previously unsuitable lung is made suitable by using this amazing technology called Vivo Lung Perfusion or an EVLP. Thank you. So now I think our next speaker will tell in more detail about how to run the circuit and how does the data shows as in the last 10 years or the previously, and how it has improved the donor lung usage. Over to Dr. Srichar.
Thank you, Dr. Vimi Varghese, for that presentation on the basics of EVLP. Dr. Ramachandra, sir, we welcome you to the webinar, sir. We are extremely honored to have you as part of the expert panelist to discuss about a topic which is practically a very less heard of in the Asian continent. So we would like to ask you to enlighten us on the more details of ex vivo lung perfusion, if you.
Good evening, Dr. Sricharan, Dr. Vimi Varghese, Dr. Venkatraman Kola. You guys are amazing. You guys are doing a fantastic job. I had the privilege and honor to be with your group in February for the Broncos meeting, and you guys have done a fantastic job. I had no idea. I left that system and then started practicing here after I immigrated. it has been almost 30 years, and it was an eye-opener what you guys are doing there every day, saving lives by the second and by the number and by every day. So it's an honor and a privilege to be with you guys. So I think Dr. Varghese started off with a blast and a bang, I have to say. It was a fantastic presentation. My apology, I joined a little late. Uh, Traffic jam, there was an accident, my apology. Uh, just to segue into Dr. Varghese's present, can you guys hear me properly and see me?
Yes, sir. Yes, sir.
Yes, yes.
Excuse me. Oh, good, good, good. I was wondering how to, oh yeah, share. I found it. I have some surgical videos. They are about 7 to 8 minutes. They will segue into the meticulous presentation Dr. Varghese has already done. Uh, excuse me. I wanted to start off with a little bit of a historic perspective, just to see where we started and where we are today. We just get to make sure. Can you guys see my presentation?
Yes, sir. Yes, sir.
Oh, got it. And can you guys also see me?
Presentation we are able to see, sir.
Oh, oh, okay. In that case, I'm probably not that tech savvy to, oh, let me see, show webinar slide control. Oh, I have it here. All right, I'll just start off. I have no conflicts of interest. Dr. Varghese already very eloquently described what EVLP is and the technique. How do I share my video also, Dr. Varghese?
Uh, our AV team, sir, can you just help, sir, about what to click? Sir, I think your screen is
You can
already
see the
shared.
screen. You can see the screen. You can actually make it full screen and you can play the video we can see.
Oh, okay. I have a quick 5 to 10 minute presentation, then a 7 to 8 minute video. That'll cover the 20 minutes and we'll take questions. Would that be okay?
Yes, sir.
Yes,
Yes,
sir.
yes.
Perfectly.
Sounds great. And how can I see myself in the corner like Dr. Varghese so nicely was visible?
You are visible to us, sir, on the corner.
Oh, oh, okay. Good. So Dr. Varghese already eloquently described what EVLP is. It is basically an outside the body, ex vivo, uh, perfusion and ventilation platform that is expected to recover some of the lungs that are deemed not
Sir,
usable,
can you
like you
make
said.
your screen, uh,
Full screen,
Dr.
sir.
Ramachandra, can you make your screen full screen?
Full screen. Let me see. How do I do
Sir,
that?
the below button, sir. Below, sir. Below.
There is a
Uh,
TV screen button kind of.
Is that the full screen webinar?
no.
Show participants and contents. Oh, yeah. Is that
Uh,
better?
Sir, just if you're using Windows, just press F5.
F5?
F5.
Oh, yeah. Is that better?
Yes.
Got it. Hmm. Sounds good. You have the full screen?
Yes, sir, we have.
Yes, sir.
Okay, great. So EVLP technique, Dr. Varghese already described it so well. I will play that through the video, and anytime we can pause, and I'm happy to take any questions. The purpose is as he rightly pointed out, donor pool expansion. In addition to that, you not only have an opportunity to investigate the lung health, number one. Number two, also to investigate whether these lungs are transplantable, they can be utilized instead of discarding them. And also, number three, you also have an opportunity to recondition the lungs like he described. So just a historic perspective, lung transplantation, the lungs, i.e. transplanted lungs, they started their journey as part of a combined heart-lung block. The first combined heart-lung transplantation was done on 9th March 1981 by Dr. Norman Shumway and Dr. Bruce Wrights. These are the two pioneering surgeons. This was Dr. Bruce Wrights' project in the lab for about 8 years, and it was validated in mammalian animal models, which is rhesus monkeys. And after the proof of concept, FDA approval was requested, cleared, and the surgery was proceeded. Once publications and global acceptance and proof of concept was proved in 1981, Toronto takes the accolades for single lung and double lung because hearts are being done, combined heart and lungs were being done. Why can't we just do lungs? We don't need the hearts. So Dr. Cooper and Dr. Patterson's team, they were the pioneers with respect to establishing isolated lung transplantation. And indications, just in brief, you need to fulfill at least three criteria. Patients with any kind of end-stage lung disease where maximal medical managements have attained a plateau and you're not able to move the needle any further. And then the 2-year mortality risk is deemed greater than 50% without a transplant. And you also need to make sure you check off the boxes that fulfill that. After transplant, there is a high likelihood of 90-day and 5-year survival post-transplantation based on overall patient's medical condition. What this exactly entails and means is you need to have total lung failure, but the rest of the parts of the body should be pristine and in working condition, meaning as minimum possible comorbidities as possible. This is a quick snapshot. It's the international registry from ISHLT. If you notice, the single lung transplantations have always existed, but they plateaued. And the double lung transplantation is the choice procedure. And notably so because you can see even under 1 year, if you look at the survival curves for single lung versus double lung, even as early as 1 to 2 months, the survival curves separate under 1 year. And clearly, the double lung transplantation recipients, they have far superior survival. As the transplantation field started expanding and more transplants were being done, we felt like the community that we are hitting a plateau because the lung procurements rate were abysmal, about 15 to 25%. What that means is of all the donor organs, when somebody goes on a procurement run, only about 1 in 4 to 1 in 7 lungs are procured. The rest are discarded or wasted. And needless to say, lungs are the least utilized organs with highest discard rate. This leads to a significant amount of donor lung shortage. There is more number of recipients on the wait list. This leads to an acute, very closely noted and felt a painful supply-demand imbalance. This leads to and results in high waitlist mortality. Patients who are actively worked up and listed, they don't even have a shot towards being recipients. And there is an acute awareness and a need to expand donor pool. So lungs that are typically discarded that don't meet the standard donor criteria are the ones that need to be investigated to see if these lungs can be utilized, as Dr. Varghese has pointed out. When you talk about standard donor lung criteria, these are usually not too elderly donors, less than 40 pack years of tobacco smoking, PF ratio that is very acceptable, greater than 300, and usually donation after cardiac death is so impossible to predict how the DCD run goes. So you want to make sure these 5 criteria are not extended in an extreme manner. These are the standard donor criteria. So basically the programs are trying to stay within safety net and safety limit so that they don't risk taking marginal lungs with a marginal or a poor outcome from the recipient. So in order to practice extended donor criteria in the last 2.5 decades, programs on a case-by-case basis, depending on their capacity to absorb the risk, they started slowly extending the standard donor criteria. So this is a classic indication where you want to make sure the extended donor criteria are tested to see if they are successful. And EVLP is the platform to try to put these lungs to test to see if they can be utilized. So naturally, the extended donor criteria, just for a recap, elderly donors where you're doubting the health of the lung, allograft, anybody who has a longer tobacco smoking history, like the cutoff is over 40, any PF ratio where the PF ratios are sagging, the lungs are a little wet and soggy, and any lungs from a DCD donation where you have very less control, these are the lungs typically that are to be put on EVLP platform to be tested whether they can be utilized. So as Dr. Varghese has pointed out, EVLP has emerged as a significantly transformative technique. And this seems to be a viable solution for evaluating and rehabilitating donor lungs that would otherwise be deemed unsuitable and discarded. So it's an extracorporeal perfusion platform where you perfuse the lungs, you ventilate these lungs after procurement, and maintain the lungs, and then evaluate their health and their gas exchange criteria for the next 4 to 6 hours, or even sometimes longer, depending on your experience, outside the body in a closed contained system or platform. Lungs are ventilated and perfused, and sometimes you can even treat them and recondition them. So basically, the EVP goals and benefits are you have an opportunity to evaluate these marginal lungs of uncertain viability, and you need to be very proficient with ex vivo platform operations. So there is an extreme high degree of skill that is involved with highly skilled surgical and medical personnel. The goal is so that, some of the lungs that are potentially discarded in the past, they can be reconditioned so that they can be transplanted. Less lung discard rates of potentially transplantable lungs. It significantly allows expansion of donor pool, at least in the United States of America. The utilization rates used to be about 15 to 25%, and they still are, because this is slowly being embraced, and we are not there yet as much as some of our European colleagues and Canadian colleagues in Toronto. It allows expansion of the donor pool. If you look at some of the publications out of Toronto and Europe, from 15 to 25%, you can increase and expand the donor pool and utilization rates exceeding 40%, which is phenomenal and transformational. It also decreases, in addition to that, once you test these lungs and they successfully pass the benchmarks, you not only are procuring and transplanting lungs that have been tested on an EVLP platform, it leads to decreased incidence of PGD and reperfusion injury rates. And the goal is also, as they are being reconditioned, you're hoping that with less PGD, there is faster recovery of the recipients. Again, this is a static pictograph of how this is. The lungs are intubated, and the endotracheal tube is connected to a mechanical ventilator with lung protective strategy, like Dr. Varghese has pointed out. And then you have an antegrade circuit where you just have basically a centrifugal pump. And of course, this is part of a standard extracorporeal circuit of any kind, including ECMO, et cetera. You guys are all familiar. The pump plus the heat exchanger connected through a membrane to a leukocyte filter and a flow probe. The flow probe consists of monitoring both the PA pressures as well as left atrial pressures, so that you have a perfusing head and a receiving trough. And you want to make sure the deltas and the pressures are very closely controlled. Dr. Vimi has given exquisitely the details of the plateau pressures that are targeted, and also the perfusion and what percentage of cardiac output. And like he rightly pointed out, with the heat exchanger in the circuit, It's not a cold static preservation anymore. It's a normothermic dynamic, not only preservation, but active real-time monitoring, evaluation, and reconditioning of these lungs. I will stop here. I will run the video, and after that, we can take any questions if you guys are okay. Let me see if I can share.
We begin
Can you
by
guys see
priming
the
the circuit.
video?
No, sir.
Okay. I think I probably should close the...
AV can you ask, can you just help, sir? I think his screen is not visible.
Oh, screen is not visible. You know what? I think I need to close
Close
this.
the PPT presentation, open that video and share the screen.
Got it.
Somebody from the digital team, are there somebody?
Yes, sir.
Yes, I think.
Close the share option, sir.
Thank you. Thank you.
Yes.
Yes.
Can you see the video?
Yes, sir.
Yes.
2 liters of steam perfusate solution is added to the
Can
circuit.
you hear the audio?
Yes, sir.
Awesome.
The circuit consists of a centrifugal pump, an oxygenator used as a deoxygenator, a flow probe, and a leukocyte filter. A one-way valve is also present. Medications are then added to the circuit. 500 milligrams of imipenem and cilastatin, 500 milligrams of methylprednisolone, and 3,000 units of heparin.
Can you hear me? I'm going to pause intermittently to make sure things are clarified because it's a short video. Can you guys hear me?
Yes,
Yes,
sir.
sir.
Great. So basically, long story short, the most important thing is it is an antigrade circuit. So you need that one-way valve, extremely important, so that there is no sort of like stalling of the perfusate, because the perfusion pressures are very, very low and controlled. You basically are mimicking a pulmonary arterial circuit and a pulmonary venous drainage circuit in an ex vivo platform situation. So you have to be as close to physiologic norms as possible. And the antibiotic doesn't have to be imipenem and cilastatin. Depending on what your local bacterial milieu is, you can modify. You can add vancomycin, you can add cefepime, depending on what kind of organisms you're seeing. I'll just throw an example. The most common bug in our facility is Klebsiella pneumoniae, and 80 to 90% of the time, it is susceptible to third-generation cephalosporins. It may not be true to institution. The 500 milligrams of methylpred is a must. It not only mobilizes the epithelial and surfactant function, but it tries to decrease the IL-6 and the downstream pathways.
The lung block is then prepared. The lungs are then inspected for any obvious injuries sustained during
Remember,
retrieval
these
or
lungs were
transport.
procured by the donor team. They were deemed not utilizable at this point in time, or these were procured from DCD donors, donation after cardiac death, where the death was uncontrolled. So in these two situations where the standard criteria were not met, questionable health of these lungs, that's when they go on the EVLP platform. So what this means is they were already procured. they were either locally procured or they were flown from elsewhere. So these lungs are already under cold ischemic time phase 1. It's called CIT phase 1. And I can answer any questions after that. Once you put it on EVLP and you condition, they're going to go back into the bag packed and then shipped away to wherever they need to be utilized to be transplanted. Or if the institution is running this, they are kept in the institution where there is very shorter cold ischemic time, CIT phase 2. Cold ischemic time never hurt anything or anybody. So that is one of the reasons why we are able to get through without much trauma and increasing the procurement rates. I just wanted to clarify that.
The atrial cannula is then measured and cut to an appropriate size to fit the atrium. It is sewn in place using a running fluoroproline suture. 2 pulmonary artery cannulas are available. This one is meant for when the main pulmonary artery is available. In this circumstance, where the main pulmonary artery is not available, a conical cannula is used in its place. It is also sewn in place using a running proline suture. The trachea is then clamped distally and opened to prevent deflation of the lung. The airway is suctioned clean and an endotracheal tube placed in and secured with number 2 silk ties. You can now see the 2 cannula in place as well as the endotracheal tube. A back table retrograde flush is then performed using 1 liter of cold Perfidex.
This is extremely important. The retrograde flush is absolutely imperative. Although in this video, my colleagues are indicating 1 liter of retrograde from the left atrial cuff back, there is no limit to the 1 liter. Say, for example, after 1 liter, you're still seeing a red effluent and you're seeing some clots. You need to continue the retrograde flush until it looks pink or not even pink to clear. That's the most important thing. It is extremely important to make sure the retrograde flush is successful.
Often small clots and debris are seen in the effluent. The dome is then placed on a sterile table and the circuit attached to it. A small sponge is used for traction. Here you see the schema for the slow rewarming and reventilation of the donor lung on the EVLP circuit. In practice, everything is pre-calculated and written on a whiteboard within the operating room. The lungs are then hooked up to the EVLP circuit. The circuit is divided between clamps and then run at a slow flow to allow for de-airing of the lung and cannulas.
You guys can see how clear it is, the antegrade flow into the pulmonary artery. In a short while, you'll see the effluent once the atrial cannula is also de-aired.
Once the pulmonary artery cannula is largely de-aired, it is connected to the circuit. Similarly, when the left atrial cannula is largely de-aired, it is then hooked up to the circuit as well. The clamps are then removed and anterograde flow through the lung is allowed to occur at 10% of the targeted full flow, which is 40%
See how
of the
clear the
donor
circuit and the effluent is. That's the most important thing. You need to flush out all the cellular elements as well as the heme and the products and debris.
cardiac output. Care is taken to ensure that the cannulas are straight and not kinked. Pressure is monitored at the pulmonary artery and left atrium. The reservoir is raised or lowered to maintain a left atrial pressure between 3 to 5 millimeters of mercury.
There was no mention of the pulmonary arterial flow pressure. Usually you want to limit it to 15 millimeters of mercury or less because that's the MPAP. It is equivalent to mean pulmonary arterial pressure in the circuit.
After about 20 minutes of perfusion, the ventilator is turned on. The clamp on the trachea is then removed and the lung allowed to ventilate slowly. No recruitment maneuver is performed at this time to prevent lung injury. As the lung is now removing CO2, it is important to start the deoxygenating gas in order to maintain stable pCO2 levels. At 1 hour of perfusion, the lung is recruited and objectively evaluated.
Remember, when you're objectively evaluating every time, part of the lung protective strategy is to minimize FiO2 as much as possible, which is the maintenance. But at every hour, when you're evaluating the health of the lung allograft and how well it is recovering from your interventions, it is important to dial up the FiO2 because you're looking at the PF ratio as one of the scoring points, whether these lungs are recovering and are they able to be utilized.
The settings on the ventilator are increased to have FiO2 of 100%, a rest rate of 10, and a tidal volume
If
of
you have
10 milliliters
noticed,
per kilogram.
during the maintenance, FiO2 is room air, 21%, and the tidal volumes typically are about 7 or under, leaning towards the lung protective strategy. But at the time of evaluation, you want to maximize the recruitment and the atelectasis. Hence, the reason why tidal volume is upped briefly to 10 mils per kg. And also your FiO2 is briefly increased before you do a sampling gas and then see how well the lungs are recovering.
Physiologic parameters including pulmonary artery and left atrial pressures, peak and plateau airway pressures, and static and dynamic compliance are recorded. The level of perfusate in the reservoir is also measured as a surrogate for perfusate loss during perfusion. Blood gases are then taken pre-lung and post-lung in order to measure PO2 and pCO2, as well as other biochemical substrates such as lactate. Here is an example of a pre-lung and a post-lung blood gas measurement.
Looks fantastic. And an anaerobic environment is not a problem at all. One other thing to make sure that you're monitoring these metabolic parameters is, if you all remember, the cold static preservation at 4 degrees seldom generates free radicals or acidic metabolites because it's hypothermic. But if you remember, this is a normothermic preservation and reconditioning circuit. So naturally, there is not much of an inhibition of metabolic parameters. So you're running it at normal temperature, which is about 36 to 37 degrees. Hence, the need to make sure that you are maximizing as much as possible, optimizing all the metabolic parameters in the milieu.
Further lung evaluation occurs by bronchoscopy, which allows for direct visualization of the airways as well as for toileting of the airways.
When you're monitoring the reconditioning and recovery of these lungs on the platform, it's a quick, easy, dirty way to remember you're assessing 2 alphabets. There is only 2 things in the lung. One is the V, ventilation and the associated parameters, Q, perfusion and the associated parameters, antegrade and then retrograde and how the circuit is closed.
X-rays of the lungs are also taken. The images can be compared over time. A lung deflation test is also conducted to assess for pulmonary edema.
If you're monitoring parameters as every hour goes by, your compliance is worsening, the lungs are looking stiffer, the X-ray shows a little bit of pulmonary edema, that is a need and time for intervening with IV diuretics. You can give diuretics and then monitor a repeat chest X-ray and gas parameters to make sure you're moving in the right direction.
Real-time perfusate cytokine testing is also performed in order to generate the Toronto lung score. Here is a schema of the EVLP workflow. Lungs are recruited and evaluated hourly. A decision to transplant is usually made by hour 3 of EVLP. Hourly reports are sent to the surgeon by email to assist in their decision. At hour 4, or at the discretion of the surgeon, the lungs are prepared for separation from EVLP. The FiO2 is increased to 50% in order to store the lungs with 50% oxygen within them. The heater cooler is then used to cool the lung. When the lung is adequately cooled, the airway is clamped with the lung inflated.
So they're talking about once the lung is reconditioned, parameters improve. Now you've deemed that these lungs can be utilized and they are transplant eligible. You're basically preparing the lungs to be taken off the platform, repackaged. Same thing again, it's a cold ischemic time phase 2 so that they can be utilized to whichever recipient it's going to go to, whether it's in the same center, if they have an EVLP platform or facility like Toronto or some of our colleagues, or it needs to be shipped back to wherever the destination center is. That's when the clock starts ticking for cold ischemic time phase 2. And there is plenty of studies and publications that showed that cold ischemic time 1 and 2, the addition of the second cold ischemic time does not have a negative impact. And Dr. Varghese already pointed out with respect to outcomes on these transplanted lungs that were reconditioned on an EVLP circuit or a platform.
The cannulas are then clamped in order to stop flow. The cannulas and ET tube are then simply cut in order to free the lung from the circuit. The lungs are then transferred to a bag over ice. 1 liter of cold Perfadex is then used to flush out the steam and further cool the lungs.
So this is almost partially, it mimics the initial donor procurement where you do the antegrade flush and retrograde flush, get rid of the steam solution, and then it's at 4 degrees centigrade. So you're inducing a phase 2 of the cold static preservation again.
The cannulas are then removed using a knife. The trachea is stapled in order to remove the ET tube.
If you remember, this is how the original lung block came in. So you've put it on the platform, you've gone through all those serial steps, you monitored real time, 4 to 6 hours, whatever time it takes, reconditioned the lungs. Now they are transplant eligible. You've put them back, packaged, and then they're ready to be utilized.
The lungs are then bagged and placed within a cooler for transfer to the recipient operating room.
I think I will stop here. Can you guys see the slideshow now?
No, sir.
Oh, okay. So I should probably, yeah, one more time.
Stop sharing and again share the PPTs.
Okay,
Yes.
Now you can see.
great. So basically, long story short, we talked about the technique. I hope I didn't take too much of your guys' time. We talked about all the pros and everything, watch the technique. Some of the cons I wanted to mention. this is not an esoteric technology that can be made available in every transplant center. It is very expensive. It takes an extensive amount of training, learning curve, and adequate skill to the personnel. It is a high skill technique. It is very resource intense. And future directions, like we were chatting about, the DCD donor pool has not been tapped yet. There is so much of literature starting in late 90s, starting with Loyola and Toronto. These two are the leading centers with respect to DCD procurement. The uncontrolled DCDs are always sort of like a toss of a coin. You never know how it's going to go. Although the first lung transplant in 1964 at University of Mississippi by Dr. Hardy was a DCD donation. The lungs were procured from the morgue. They were flushed and transplanted, and the patient did fine. So it's a good indicator that DCD donation is a huge untapped donor pool that is being wasted and thrown away. It is not widely accepted because of some ethical and legal considerations, but there is a growing evidence and mounting body of consensus that is favoring DCD donation that is yet to be tapped. The projections are you can elevate the procurement rates from 30 to 40% to almost 60%, meaning, can you imagine 1 to 2 lungs out of 10 utilized versus 6 lungs utilized? It gives you a huge opportunity to close the gap between the supply and the demand, and also a healthy decrease in the waitlist mortality. So the reconditioning is something that is being looked into with respect to future direction. There is plenty of literature coming out of Toronto program, one of the leaders, and some of the European programs, that reconditioning with anti-inflammatory cytokines via arboviral vectors transfecting these transcripts into the airway epithelium with twofold benefit. One is not only you're decreasing the inflammation, you're decreasing the PGD, but if you also can induct some immunomodulation, the intensity of immunosuppression doesn't have to be that intense with a lot of adverse effects with long term. You can also potentially induce transcripts that can promote tolerogenic phenotypes in the lungs so that there is fewer incidences and instances of acute rejection with a little bit extension and prolongation of the allograft half-life. I will stop here and happy to take any questions. I hope I didn't overshoot too much on the time. Thank you so much for this privilege and opportunity.
Thank you, sir, for that extensive presentation on the intricate working mechanisms of the ex vivo lung perfusion. So, one of the questions which one of our viewers is asking is that diuretics. How does diuretics attack when we are actually dealing only with the lungs, and what are we actually dealing with to decrease the pulmonary condition when there is no urine out, essentially in a patient who is having EVLP?
That is a fantastic question. If you all remember our medical school pharmacology, intravenous diuretics are pulmonary venodilators. I mean, they are pulmonary arterial dilators so that they decrease the preload. So what it does is, in a way, it basically relaxes. There is vasorelaxation so that your flow efficiencies increase, leading to a delta between intravascular pressure and tissue hydrostatic pressure, leading to fluid shift from interstitial total lung water back into the vascular tree. Does that make sense?
Yes, sir. Yes, sir. Sure. Yes. So thank you so much for that.
Excellent,
And
excellent question. Very well thought of.
one more question we have is that now we know that we're not actually dealing with volume of distribution. So what about the dosage of these drugs, especially lungs which are looking infected and which requires antibiotic therapy? So what would be the dosage of antibiotics when we are actually giving them a decrease, or do they remain the same?
They're all absolutely the same. It's a two-part question. Great question, by the way, Dr. Sricharan. The first and foremost is you've already started reconditioning them in case there is an infection, pending cultures, because you are taking cultures, not only blood cultures from the donor, but endotracheal cultures from the donor, and also at the time of procurement, and also when you're putting it on EVLP. So you not only have airway secretions culture, you also have, by the way, when the lungs arrive first into the reconditioning unit, when you're flushing it with steam solution, the effluent is not wasted or run off. It is procured and sent for cultures, number one. Number two, once you flush out the steams and you're incorporating your antibiotics, and after that, you flush out the antibiotics because some of the antibiotics do sort of like get outside the vascular tree into the tissues. So you're basically having a little leg up, but the real game starts when the cultures come back and the lungs are sewn in, and you don't treat anything differently than what you normally do immediately intra-op and post-op for that recipient.
Okay, sir. Thank you. So for procurement of the lungs, the donor generally the like individual lungs are procured individually during the donor harvesting, right? So we are suspecting an EVLP and we take the tracheal dissection, or for all, is it a common practice that you take the lungs and two lungs en bloc? Because whatever that is shown in the video is actually showing two lungs which are connected to the trachea en bloc, but the practices may vary where each lung is taken out separately. So will the practices change, or when we are suspecting EVLP, so when we are suspecting EVLP and we are taking out the lungs, do we take it as an en bloc or any other?
Great question. Remember, you always procure discarded lungs as an unblock. Remember, these are discarded lungs. So you're not going to separate them at the time of procurement to ship them to program A or program B. There will be some instances where sometimes only one lung is procured, the other lung is discarded. And usually the transplantability of those are not very easy because the lung comes very completely collapsed and there is no way to optimize that to make sure that you procure it. So once the discarded double lung block comes in, while reconditioning, if you determine that one lung gets through the finish line and the other lung doesn't look good, typically all these recipients are listed for either lung or double lung, meaning either right single, left single, or double lung. So you take them as they come as double lung en bloc. You attempt all the reconditioning efforts. Sometimes you can extend the time. If it ends up being a single lung, then you procure the single lung and then pack it and ship it. Did I answer the question?
Yes, sir. Yes. I just last question from my end, sir. So there is actually a gas exchanger in the EVLP circuit, which is like giving 6% oxygen, 8% carbon dioxide, and almost 86% nitrogen. So like this is not from the ventilator, right? So we are actually giving it through a oxygenator. Like, what is the purpose of this gas which is being given to the EVLP?
Oh, the 6% CO2?
Yes, yes.
There is so much of research. If you go back to lung protective strategy in ARDS or acute lung injury, CO2 is protective. It is not harmful at all. So there was a nice small animal and a large animal model in 80s that was validated by, there is a group for lung injury working group in United States and North America. One of the lead authors is Tierney. I can send some slides actually to Dr. Varghese and he can share that.
Sure.
So it has been historically shown, and the first earliest adapters and the continuing adapters are Canadian groups. So what it showed is lung protective strategy, permissive hypercapnia. If you remember, we always study and read about that. Permissive hypercapnia is facilitated by wild swings in inflation and deflation, leading to mechanical shear stress injury. As soon as you minimize that and allow permissive hypercapnia, it equals to less IL-1, IL-2, IL-6, TNF alpha, less neutrophil recruitment. And last but not the least, less disruption of the entire airway inflammation as well as endothelial inflammation. Keeping this in mind, even in routine ARDS protocols in a lot of Canadian ICUs, they pump CO2 into the circuit so that the CO2 is not less to facilitate healing from the hypercapnia. Of course, all of this was standard routine protocol until 2009 H1N1 with development of CardioHelp and small footprint circuits where the ECMO took off. Until then, CO2 was integral part of the gases that were pumped through a routine ventilator circuit. So it comes from that mindset, understanding pathophysiology and the published literature.
Okay.
So CO2 is healing, actually. It is anti-inflammatory.
Okay. So I have all my questions answered quite nicely. Dr. Vimi, do you have any more questions, or from the panelists, or from the audience? Do we have any questions?
Any ICU related questions?
What cytokines are tested for lung well-being? Is one of the is a question from Professor.
Typically, IL-6 and IL-10, and you can have point of care testing just like the blood gas. It is generated in the report. So the IL-10 marks the inflammation stop signal and the healing, whereas IL-6 is just ongoing inflammation. You can sometimes plan your steroids after transplant based on the cytokine profile too. It's not validated, but it just gives you an understanding of the basic pathophysiology.
So one more question from my professor is electrical impedance tomography possible with an EVLP that endotracheal TPs can actually give us more information about the relative diversity in compliance across the two lungs? Has it been tried?
I'm sure it was tried, particularly with differential compliance.
Yes.
A couple of comments about that. It's a great question. The sentinel event that leads to brain death of the donor leads to explosive cytokine release, as you all are aware. And the sentinel event at the time of brain death also leads to a certain amount of aspiration. Sometimes it's bilateral, but most of the time it's a straight shot into the right dependent lung zones. And when that happens, it's not uncommon to expect a little bit of differential plateau pressures. But as you're reconditioning, it is not a normal thing to monitor the differential sort of like compliance. Rarely it happens. Whenever you have a differential compliance, it is important to monitor the PF ratio. Say, for example, after 3 to 4 hours, your PF ratio shoots up to 500. This is a good time to make sure you are basically, you have the left atrial cuff. You can even put a little needle and sample the pulmonary venous blood and then assess which lung is getting better. On the x-rays, you can tell which one is going to be worse compliance and which one is deteriorating. And that may be one of your calls to say, I'll take a chance and do a double lung transplant, or I'm not going to, the right one looks so horrible, I'm going to discard that and I'm just going to procure the left lung. Just to minimize, this is all based on, this is the new thing that you probably heard from the last 2 to 3 ISHLT meetings and the proceedings. It is not enough if you look at the donor criteria. It is important to match the donor risk criteria with the recipient risk criteria. I'll give you an example. Say, for example, the recipient is somebody with severe pulmonary hypertension. You know very well that the single lung is not going to work out.
Yes.
So in the same instance, if somebody has normal PA pressures, they're a little on the older side, close to 70 or above, a single lung probably is a good way to discard the bad lung that is lagging behind so that you can recover them quickly through a short operation and a faster recovery time.
Yes.
And this is a common strategy to make sure you continue to do with the EVLP lungs. There should not be treated any differently. Once the lung recovers, you're switching back after cold ischemic time 2 to your usual evaluation criteria, and that includes matching the donor and the recipient risk criteria.
Yes.
Great questions.
So, there was one more question from our audience, like, what is the level of carbon dioxide, at where should we draw the line? Where is it an anti-inflammatory, and where is it actually causing precipitous respiratory acidosis?
So, two things, the circuit has fixed amount of CO2, which is 6%. Depending on your compliance, your ventilation parameters, if you go back again to the lung protective strategy and ARDS protocol, you don't want the pH to dip far below acidosis parameters, 7.15 to 7.21 ex vivo. In vivo, it's a different thing where we target 7.3 OPH and above. So once you get into too much of acidosis, your PF ratio is not improving. That's when you want to make sure you either decrease the CO2 or you do a couple of recruitment maneuvers to make sure, depending on your visual, depending on your compliance, X-ray, etc. So it's an ongoing dynamic evaluation. It's just that the ex vivo lungs are a little bit more accessible and easier to manipulate than in vivo sometimes.
Thank you, sir. That was a extensive discussion we had on a less heard of topic for us. So if there are no further questions from the panelists or from the audience, we will close the session.
We
So,
thank.
Yeah, go ahead. Sorry.
It was a really eye-opener for all of us. We thank from our bottom of our heart, and it's a privilege for us, you being here as a part of this program. Thank you so much. Many more to come. We wish you all the best for your future endeavors.
Sir, Dr. Kola, you're being very effusive and generous. There is nothing in our profession as medical professionals, there is nothing more. What is the right thing? I mean, this is like a shot of youth in the arm. By discussing with our colleagues certain complexities, we become younger, we age less, and probably even sometimes gain a little bit more longevity, I feel personally. And is everybody Telugu speaking on the panel here?
Not necessarily, sir. We actually these are all actually both Facebook and YouTube uploaded videos after the session. So we
Okay.
see maybe 100 or a few on the live, but in a couple of days we reach to close to maybe 5 to 10,000 audience across India. So it's not just Telugu speaking. It's a wider audience. It's not just critical care. We see from ECMO Society of India, we see Pulmo guys looking at, transplant guys looking at these webinars. And we also keep some basic sessions for postgraduates in critical care and other specialties too. But this was a special session, a very, I think, less known topic to many of us. So it's an eye-opener and a lot of insights into this EVLP. And thank you very much for being a part of this program.
Oh, you're most welcome. It's such an honor and a privilege to be with you guys. I can tell you guys are moving the needle and progressing it in such a rapid and efficient manner. Anytime it is so gratifying to share some of the insights. I wanted you guys to go away with one thing to remember. It is when you ask an intelligent question, that's when I look up and I learn too. So this is an important thing. It's a dual benefit. So please don't think that I am the expert here and there is a delta here. No, absolutely not. You guys are seeing it and doing it every day. So it is like, please consider this as a collaborative, congenial, cross-pollination, sort of like a brainstorming session. That's exactly how it should be. And
Thank you.
And it'll make us all young. I hope I didn't belabor this and extend this unnecessarily. And even if
Not
there
at
are
all.
any questions, please don't hesitate. Dr. Vimi has my WhatsApp number. You guys can text through WhatsApp any questions or concerns or anything. And if I can share any other materials you guys are interested in, please don't hesitate.
Thank you. Thank you, Vimi, also in helping us in being in touch with Dr. Ramachandra and bringing this program. Thank you for that presentation too.
Thank you, sir.
Thank you, sir.
Thank
you
you,
so
sir.
much.
Thanks, Dr. Sricharan, Dr. Kola, Dr. Varghese,
Thank
everybody.
you.
And
Thank you.
Yashoda Hospitals for the privilege and the opportunity.
Thank you.
Thank you.